Hello, everyone, and thank you for joining us for what I hope will be an interesting and informative discussion around some of the latest data in rheumatology. My name is Professor Peter Nash from Griffith University in beautiful downtown Brisbane, and today we're very fortunate to be joined by Professor Phillip Helliwell, who's a Professor of Rheumatology at the University of Leeds in the UK. It's a pleasure to have you with us today, Phillip, and thank you so much. We'll be talking about one of your recent review articles in the British Society of Rheumatology journal Rheumatology. It was published quite recently. I got it in October 2024. And it's really looking at a very topical area in psoriatic arthritis, trying to distinguish whether radiographic axSpA with a rash is the same or different to axial PSA. And no one on planet Earth would be more suitable to discuss this topic than you, Phillip. You've been publishing on this particular topic for a very long period of time. So just as an introduction, could you tell our audience a little bit about yourself, where you work and what your interests are?
Yes, thank you, Peter. It's nice to be with you. I've been working in rheumatology for about 50 years now, in various places around the world. In fact, starting in Australia, strangely, and then New Zealand, and finally got back to Leeds and worked with Werner Wright and John Moll, who, of course, are the fathers of spondyloarthropathy. And I worked with Werner Wright for about 10 years before he sadly passed away. And he always wanted me to take over the mantle of that, and I've been trying to do that since. Obviously, my research has been in spondyloarthritis, particularly psoriatic arthritis, but I've also had interest in bioengineering because that was my first commitment, as it were, in rheumatology, and in foot and ankle disorders. We've got a large foot and ankle group in Leeds. So yeah, that's my background. As you say, I've been publishing in spondyloarthritis for many years now. And it all started, I guess, back with Werner Wright in the 70s and 80s.
Tell us a bit about Werner. What was he like, Phillip? Was he a wonderful clinician, observer, researcher? What was he like?
He was a bit quixotic, really. He had a very raucous laugh, and you could tell where he was from time to time when you were around the building, when he was discussing things with people. He was a good mentor. He was very encouraging and very cooperative. And in fact, I've learned many of his habits. He used to have a big A4 notebook, and I have some of these old notebooks in my collection now, but he had about 50 of these on his shelves, and whenever he went, whatever meeting he went to, the notebook was opened and notes were made. And this was particularly true at international meetings. He never went into a session unless he was chairing or speaking. He just sat outside the session. And then when people would come out and say, "Oh, Werner, did you hear that? And this is what happened." And it went into the notebook as though he'd been there himself.
So tell us, were you around when they first started talking about PSA as a separate condition to the rheumatoid and everything else, and including Behçet's and God knows what else?
Yeah.
How was it received, Phillip? What did the general rheumatology community think?
Well, as it happened, Peter, I was in 1973 when that first psoriatic arthritis paper was published. I was a medical registrar in Leeds. I wasn't working in rheumatology. So all this went on, as it were, without my knowledge until I joined Werner Wright and his team in the early 1980s. So I wasn't aware of all this discussion. But of course, I've gone back and looked at the Heberden Society meeting minutes. And clearly, there was some heated discussion around the inclusion of various of these conditions at the time. And indeed, there's still controversy. I mean, obviously, Whipple's disease, which was part of the spectrum originally, has now been removed. And in fact, I published with Werner on that. But Behçet's disease was taken out, and now he's making a bid to come back in again. So,
but what about the 5 kinds of PSA? Was that accepted by the community or thought to be heresy?
oh, absolutely. Everyone thought that was wonderful. But
Right.
I've questioned this as well. And we went back and looked at John Moll's original data, which was buried in the cellar at the research unit in Leeds. And Paul Healy, when he was with us, he's a New Zealander, went into the cellar and brought all these mice-eaten notes up and reanalyzed John Moll's data. And we didn't get the same subgroup proportions that he did. So where that came from, I have no idea.
Well, tell us a little bit about this controversy now. Is axSpA with psoriasis different to axial PSA? And if so, what are the things you consider when you think about the two?
Well, this argument has been going on for years. I remember an ASAS meeting in Rome in the early 2000s where Maxime Dougados presented data on patients with axSpA with and without psoriasis and showed that there was no difference between them. And I think it depends on where you're coming from, because McEwen originally looked at the radiological features of axSpA, known as AS then, of course, and axial involvement in PSA, and quite clearly showed differences. And we were able to reproduce those differences when we looked at, did a similar study in the late 1990s. And I think the problem is, Peter, that there are people with psoriatic arthritis who have classic ankylosing spondylitis. But there's another group of people who have an atypical form. And of course, these two forms are mixed together. So depending on how you look at your cohorts, you may get different proportions of classic disease or atypical disease. And that may lead you to different conclusions. But, there's now radiological data, there's genetic data, there's clinical data, and then there's the response to treatment data, which we want to discuss in a little bit.
So really, I think that if you sit in a back pain clinic like Maxime Dougados, you're going to see classical AS, and 9% of them are going to have a rash. And he's going to think that that is no different to AS without a rash. You and I sit in a peripheral arthritis clinic, and we look at the back just like we look at the peripheral joints, and we notice there's different phenotypes. So can you define the phenotype of of axial PSA for the audience so they know what that element looks like?
Yeah, thank you. If you take the group as a whole, then the following differences are clear. Clinically, patients with axial involvement in PSA are older at presentation. They're less likely to be male. They're less likely to have symptoms. And they're less severe. They have less loss of movement and so on. And that is associated with radiological changes, which are less severe as well. So there's patchy involvement of the spine, asymmetrical involvement of the sacroiliac joints. This alternative phenotype that we're proposing is not only less severe, less extensive, asymmetrical, but different in morphology. If you look at the morphology of syndesmophytes in axial PSA, they're different quite often. They're big, hanging, dewdrop type syndesmophytes, the so-called inverted teardrop of bywaters. They're chunkier, there's more bone, and this sort of reflects that new bone formation you see peripherally in PSA. Whereas in rheumatoid, you get these sharp erosions, you get extra bone in psoriatic arthritis, and that's what's happening in the spine. There's new bone formation as a response to a florid manner that leads to this different syndesmophyte morphology.
And do they have more cervical involvement, Philip?
I'm not sure. It's said they do, but Will Taylor, who I admire greatly and worked with me on Casper, reanalyzed that paper of ours in the 90s, and he said, no, they don't have more cervical, they have less lumbar. So the ratio of cervical to lumbar is different, and it looks like they've got more cervical, but they've got the same amount of cervical, but less lumbar involvement. That's what Will concluded.
Wonder why you think they're less symptomatic, Philip?
Yeah, that's interesting. I mean, it's true generally of psoriatic arthritis. Daphne did some work with algometers in the 80s where she poked her patients with a pain device. Not sure you could get away with that now, but she said that people with psoriatic arthritis were less responsive to pain than people with rheumatoid arthritis. That was a comparison she made. So I guess that's one reason. But the other is that the disease isn't as florid, and it's occurring in different parts of the spine. As you know, Dennis McGonigal, who's a great thinker, has just published work saying that the site of inflammation in the spine in psoriatic axial disease is different to that in classic ankylosing spondylitis. There's more ligamentitis, i.e. inflammation between spinous processes, than there is in ankylosing spondylitis, where it is focused on the enthesis, the attachment of the ligament. So I guess that may explain it.
So tell us the treatment implications you were mentioning before.
That's the rub, really, because in studies that have been done so far, we've got proven efficacy of TNF inhibitors, IL-17 inhibitors, and now JAK inhibitors. But the IL-12/23 and IL-23 inhibitors have consistently been shown to be ineffective in AXPAR, ankylosing spondylitis as we know it. And those studies have included a mix of patients, some who had axial PSA. However, if you accept that in people with axial PSA, some of them will have an alternative phenotype with a possible alternative pathology, then it's possible they will respond differently to treatment. And we have done secondary analyses of the trials involving IL-12/23 and IL-23, and both those secondary analyses show that there may be efficacy for those drugs in axial PSA. Now, I can see certain people in the world jumping up and down and leaping out of their chair right now because that was secondary analyses and they were flawed in the sense that there was no good definition of axial involvement in those sub-analyses, and they were using an outcome measure, the BASDAI, which is responsive to peripheral arthritis as well as axial. And I accept that, and which is why there's now a study, as you know, going ahead, purely focused on axial PSA with imaging, MRI imaging as an endpoint. So we'll get an answer to that, hopefully, as the STAR study, which is what it's called, becomes published.
And the recently discussed AXIS study of the GRAPPA group trying to define axial PSA. Any take-home messages as far as you're concerned from that study?
No. Well, we can talk about the classic study in a minute, but I think the AXIS study is good. I think we're only at a preliminary stage of analysis, but all these patients have got psoriatic arthritis and axial symptoms, although only a proportion did have axial inflammation on MRI imaging. But that's such a large cohort that we should get a better definition of what imaging, certainly MRI imaging features of axial PSA are like. And that remains to be seen. We haven't got those analyses yet.
So correct me if I'm wrong, weren't these people on therapy? You know what I mean? So they're on a TNF or a 17, which will affect imaging, it'll affect symptoms. I couldn't quite follow that rationale.
Yes, I'm just trying to remember the patients I included in that study. I don't think any of mine were on a biologic at that time. But obviously it would do. I mean, if that were the case.
We'll just change things. We should have mentioned that the AX PSA is much less B27 than the radiographic AXPAR people. But tell us a little bit about the classic study then, Phil.
Yeah, so the ASAS classification criteria for AXPAR have been around since 2008 and have become the industry standard for including patients in clinical trials and so on. But there's been unhappiness about them. Some people say they're too loose, that you will include patients who haven't got axial spondyloarthritis under that rubric. Some people claim they're too severe. I'm in the camp that says that if you've got axial PSA, you're less likely to be diagnosed or classified by those criteria, because there's a clinical arm which requires B27, and as you've just said, only about a third of our patients with axial PSA are B27 positive. And there's an imaging arm which requires inflammation of the sacroiliac joints. Now, we know in axial PSA that that's a lot less patchy, a lot more patchy, sorry. And indeed, with axial PSA, you may have inflammation of the spine, but not the sacroiliac joints. That occurs in about 11% of cases, much less than in AXPAR. So from our point of view as axial PSA people, the ASAS criteria have not been satisfactory for classifying our patients. And indeed, one of the reasons the classic study was set up was because people like John Revell from Houston said, a lot of our Black American patients are B27 negative. A lot of people, the rest of the world, are B27 negative. These aren't fit for purpose worldwide. So the classic study was set up to reverse that position, I guess. And ASAS and Spartan, which is the North American equivalent of ASAS, agreed that they would do a combined study. And if pre-specified sensitivity and specificity criteria for the ASAS criteria were not met, then the criteria would be revised. And they weren't met. They recruited over 500 people. The specificity and sensitivity that they pre-specified didn't happen. And for 3 years, we've been trying to revise the criteria. There's been a bit of pushback here and a bit of pushback there, but I'm glad to say things are moving forward. And at the recent ASAS meeting, January this year, just last month, a number of proposals were put forward, which we will be voting on. However, at the end of the day, they won't do anything for axial PSA. These criteria are all about AXPAR, not AX PSA. And that's not going to help us.
So tell me what it would take to validate a definition of axial PSA.
Well, I think the AXIS study is going to answer that question, hopefully. So we've got data in the AXIS study for those who haven't got axial involvement in PSA. From that, we'll be able to derive clinical and radiological criteria, which we will be able to test in other cohorts, such as, I guess, the classic cohort or the maximized cohort, which was the RCT of IL-17 inhibitors in AXE-PSA. So I think we're on the road. I'm just sorry that we haven't been able to come to a compromise with the other half of this field, as it were, and have a general definition of inflammation, axial inflammation in spondyloarthritis, because we'll end up with two, I'm sure, at this rate.
All right. Well, I'm going to suggest something heretical for you to consider. I'm going to propose that radiographic axSpA plus psoriasis is Helliwell phenotype 1, and axial PSA, as you described beautifully, is Helliwell phenotype 2. And I think they're the same disease, but just like leprosy, which has one antigenic infection trigger, they have different genetics, different cytokine profiles, and different imaging and different clinical features, whether they're lepromatous or whether they're tuberculoid. So if you have psoriasis, the genes, the cytokines, the imaging is all driven by what pack of cards you're given, but it's the same disease. It's just got two ends of a spectrum. And that's why there's so much trouble separating them. And there are people that mix up in the middle. But I'm going to argue they're one condition with two phenotypes. Otherwise, you might have to describe dactylitis PSA, enthesitis PSA, iritis PSA, because they'll all have subtle differences based on what genes you inherit, what genes you don't, and your cytokine profiles, and your every other polymorphism you can think of. What do you think of that heretical notion? Helliwell type 1, Helliwell type 2.
Well, if you read the article that we're discussing in question, there's a little diagram that proposes the two phenotypes and how they intermix in each of these, as it were, diagnostic rubrics. And I think you're absolutely right. I think this is what's driving it. It is one disease. Depending on your cards, the pack of cards you're dealt, your phenotype will be different. If you're B27 positive,
you go down one road.
You go down one road. If you're not, if you're B27 negative and maybe B08 or some other as yet unidentified gene positive, then you go down the other route. I think that's absolutely right. But it's the same disease with a different expression.
Yes, that's what I think might be the take-home message for the audience. Particularly if you sit at a peripheral arthritis clinic, you'll see a different expression. It doesn't mean they don't have axial involvement. It just means it's expressed differently. So any other message for the take-home message for the audience, Phil?
I think we have to be mindful that this alternative phenotype may behave differently, particularly in response to treatment. And one of the messages I'd give is that you'd be surprised that the alternative phenotype may respond to drugs such as conventional DMARDs. I had a patient recently who presented with severe psoriasis, peripheral arthritis, enthesitis, and back pain. And his MRI showed inflammation in the ligaments between the spinous processes in his thoracic spine. It presented with inflammatory back pain, stiffness, and so on. Because of the rules in the UK, I couldn't give him a biologic up front. He went on to methotrexate. All the symptoms in his spine resolved within 3 months of starting methotrexate. It may be that this alternative phenotype has different pathophysiological manifestations that are responsive to drugs such as methotrexate, which we've never ever seen, although it's not been formally tested in AXE-SpA.
Okay, point taken. So thank you so much. Any other final comments? We've greatly enjoyed the discussion and your expertise in this area. Anything else you wanted to add?
I don't think so. I think we have to, and to be fair, much of the problems, as you say, comes from the way you collect your patients. If you're sat in a peripheral arthritis clinic and you collect your cohort that way, you're going to end up with a different phenotype of axial disease than if you're sat in a AS clinic just taking people with back pain who don't have any peripheral arthritis, who are young men who are B27 positive. And that's why the controversy has arisen, I think. Even if you look at Daphne and Rob Inman's joint publications, the differences there are because of the way that their clinics are set up. So I think we have to be mindful, and epidemiologists can inform this debate of how we collect our patients and how we look at them.
But I think the final implication really is there'll be treatment differences that we shouldn't ignore, and certain drugs that are getting thrown out, which might be quite valuable in that particular phenotype. So that's a very important message. Thank you again for your time, Philip. If you'd like to know more about this paper and others uploaded to the Immune-Mediated Inflammatory Disease Forum website, you can get detailed slide sets are available at imidforum.com. Please subscribe to this podcast on Spotify, iTunes, or other podcast media. Let us know what you think. We like to get some feedback. You can watch this on the Immune-Mediated Inflammatory Disease Forum on YouTube. And finally, you can follow us on Twitter, LinkedIn, and Facebook to keep up with all the new data related to IMID diseases coming soon in 2025. Thank you so much for your time, Philip. Greatly appreciated.
Thank you, Peter.